Hello and welcome to this session, my dear colleagues, where we're going to discuss about pelvic inflammatory disease as the topic of today. What is pelvic inflammatory disease? My dear colleagues, pelvic inflammatory disease, as you hear it, it is a condition that is caused by bacteria, mainly neisseria gonorrhoea, chlamydia trachomatis, and so many other bacterial infections like staphylococcus aureus, streptococcus pyogenes, clostridium perfringens, and so many others. It can be caused by a mixture of, it can be caused by a single bacteria or a mixture of bacteria. So who is a candidate? Who does this infection affect? It is the women or the females. So let us begin. But before we begin, I also need to let you know that pelvic inflammatory disease begins, of course, it does not begin out of the blue. It begins following exposure to the bacteria. And in which parts of the body does in which parts of the female body does the bacteria or do those bacteria affect? You are yet to know. So I request that we begin and we understand the condition that we are going to discuss from the beginning to the end in as far as this session is concerned. So, as usual, the presenter is me, myself, Dr. Manirachiza Robert. So, as we proceed, I kindly request each one of you and remind you to keep on subscribing to our Medicentia YouTube channel with the motto Limitless Knowledge. So, I have already said that pelvic inflammatory disease is a condition that affects women or females in reproductive age, or females who are sexually active, females who are in the reproductive age, maybe who have experienced an abortion and maybe some procedures have been done using contaminated instruments or in a contaminated environment. So as we proceed, before we look at the definition, let us have a look at this structure of the uterus. Look here broadly. Be keen. This is the anatomy of the uterus with all the labeled parts. Look at this structure. This is our uterus. One side, the right side, has been sectioned or it has been dissected to expose the internal cavity. As you can see, this structure is part of the vaginal canal. This is part of the vagina, which is a fibromuscular tube, and this is the vaginal canal showing the rugi. You can see we have the other parts like the lateral fornix, the cervical canal. This is, of course, the internal cervical canal. As you can see, this is the external os. So, as you look at this uterus, you can see that we have this huge mass here. These huge masses, the walls of the uterus. So the wall of the uterus is made up of what we call the myometrium. The myometrium is a muscle. So this is this block of the muscle is the myometrium. This is the myometrium. As you can see, it has been dissected, and this is what we call the perimetrium. The perimetrium, which is surrounded or covered by what we call the serosa, the serosa. And outside the uterus, you can see this area, this region is what we call the broad ligament. This is the broad ligament. Then this is this area is called the perimetrium. The perimetrium is made up of what we call the serosa. The serosa is a membrane or a sheath or a ceiling or a roof which is covering the uterus. Then this space that you are seeing that is exposed is what we are calling the endometrium. Within the endometrium is made up of what we call the epithelial linings. I can call the roof or the floor. They will have the floor that can be made up of cement, ordinary cement, or even tiles, ceramic tiles, so like that. So the tiling or the roof or the ceiling of the uterine cavity, the inner lining, is what we call the endometrium. The endometrium is made up of the mucous membranes. That is why we call it the mucosa. Likewise, when you go through this tube which has been dissected as well to expose the inner lumen or the inner tube or the inner pipe of this fallopian tube, you can see that it has the same anatomy. The inner lining is also made up of the mucosa. The epithelial linings, which you call the mucosa. Those epithelial linings, I can call them tiles, the cement, the inner cement, or the inner ceiling, like that. So this is our fallopian tube with various segments. These ones which have finger-like projections are the fimbria. The fimbria. Then this part is what we call the ampulla. Then you can see towards the uterine cavity, we have the isthmus of the uterine tube. Then you can see the body, the fundus of the uterus, the other superior component or the superior portion of the cervix. So this part is still this part which has not been dissected. This is the external view of the fallopian tube. This is the external view of the uterine tube, of the fallopian tube. So this is the ovary, as you can see, with its stalk or the ovarian ligament. So this is the external view. This is how the pelvic, the broad ligament looks like, and that is it. So in summary, on one side, our uterus is being exposed. It has been sectioned or it has been dissected to expose the internal cavity of this uterus, where that is going to be the center, the main center and the focus of pelvic inflammatory disease that we are going to discuss. So as we see, we are going to, as you look at this fallopian tube, as you look at the vagina, the vaginal canal with the rugi, you proceed to the external cervical os, to the endocervix, which is the internal cervical os, until you reach the mucosa of the endometrium, of this uterine endometrium or the endometrial cavity. We are going to be talking about the mucosa, the serosa, until we reach, we go through all the tubes and we see what happens. What do those bacteria do? The neisseria gonorrhoea, chlamydia, chlamydia trachomatis. When we look at also others like staphylococcus aureus, depending on actually the predisposing factor of pelvic inflammatory disease. So at the end of it, as we also discussed, we shall not spare the ovaries, we shall not spare this tubal as well, we shall not spare the broad ligament. We shall also talk about complications of pelvic inflammatory disease that occur beyond beyond the uterine cavity, even beyond the external, beyond the adnexal, beyond the pelvic organs, up even to the peritoneum, the heart, the meninges of the brain, the coverings of the brain, like that. So, it is, my dear colleagues, my dear brothers and sisters, it is very paramount to discuss pelvic inflammatory disease while you know the anatomy, or after reviewing the anatomy of the female reproductive system, and also the surrounding pelvic organs. So, let us now proceed. So, this is the illustration of a female body with the position of our uterus, the vagina, the vulva, the vagina, the uterus, the fallopian tubes, and the ovaries. Of course, this is the location. And this structure that you are seeing that has been magnified, they are showing us bacteria. Bacteria which cause inflammatory, which cause PID or pelvic inflammatory disease. This is just a sample of bacteria that have been magnified to show what happens within the uterine cavity. So you can see this is a lens. I can call it a lens that is helping us to magnify the bacteria. So these bacteria, it's not that these bacteria that are being represented here are the diprococci, the neisseria, the gonococcus, neisseria gonorrhoea. Much as this is just a representation, doesn't mean that it's only neisseria gonorrhoea which causes PID. I have mentioned these other bacteria that are responsible, and this, in most cases, actually, you find a mixed. The infection, you find that the infection is polymicrobial, as we are going to see. So these are the prococci. Mainly we are present here. It's only the prococci being represented mainly, but even other bacteria do cause PID, as we are going to see. So let us officially begin. Pelvic inflammatory disease or PID is an ascending infection. Ascending meaning going upwards. When an infection starts from here, from the vagina or the vulva to the vaginal canal to the cervix to the uterus, then to the fallopian tubes and beyond the pelvic cavity, peritoneum, it means this is an ascending format. When an infection starts from the vagina and goes to the uterine cavity, we call it an ascending infection. So PID is an ascending infection that begins in the vulva or vagina and spreads upward to involve most of the structures in the female genital system, as like you have seen already in the illustration, resulting in pelvic pain, adnexal tenderness, fever, and vaginal discharge. These discharges might be pus, might be serous fluid, depending on the stage of infection and how it has progressed. We see that gonococcus continues to be a common cause of pelvic inflammatory disease. So, my dear sister there, my dear brother there, don't when you contract gonorrhea, you need to be very, very careful. Don't say that because we are discussing pelvic inflammatory disease that affects the females, women, a male, I shouldn't be concerned. You actually you need to be concerned very, very fast, like any other female, because after sexual intercourse, you might be a male who carry with gonorrhea, suffering from gonorrhea or gonococcal infection, or a mixture of gonococcal and the chlamydia infection, and you have sexual intercourse. When you have sexual intercourse with your partner, you infect her. After infecting her, she's going to suffer from gonorrhea or chlamydia infection, or a mix. She gets a mixed infection, and the microorganisms from your penis or from your urethra, they travel, you inoculate them into the vagina, female vagina. Eventually, where do they end? They end up within the fallopian tubes and beyond, and they cause pelvic inflammatory disease. So as a male, don't say that me, I'm not concerned. It doesn't concern me. Me and you should also get concerned because we infect one another. They infect us and we infect them as well. So it is vice versa. So gonococcus continues to be a common cause of pelvic inflammatory disease. And the most serious serious complication of gonorrhea in women is pelvic inflammatory disease. Now let's look at chlamydia. We see that chlamydia infection is another well-recognized cause of PID. Besides these two organisms, infections after spontaneous or induced abortions and normal or abnormal deliveries, which are collectively called puerperal infections, are important causes of pelvic inflammatory disease. In these situations, the infections are typically microbial, meaning that polymicrobial, meaning that a mixture of bacterial types are involved. That's why I am mentioning gonococci, I'm mentioning chlamydia, and we are also going to see others in this picture. In these situations, the infections are typically polymicrobial and may be caused by staphylococci, streptococci, coliform bacteria, and Clostridium perfringens. We see that with gonococcus, inflammatory changes start to appear approximately 2 to 7 days after inoculation. Meaning, what do I mean by inflammatory changes? Inflammatory changes. For example, when bacteria enters my mouth, let me say when bacteria enters my mouth and it attacks the mucosa, the mucous membranes. These are the mucous membranes. And that is how the anatomy of the vaginal canal, the uterus looks like. These are like mucous membranes, the mucosa. Now, when the bacteria, for example, infects my mucous membranes, and the immune system starts recognizing it to fight it, inflammation will start. What triggers the inflammation to begin? In summary, inflammation means inflammation is in immunology. Inflammation is a defense mechanism that is mounted or utilized by the body to protect itself. But in the end, of course, we suffer because of the effects or the powers or the magic bullets of the immunological reaction. As the body is trying to defend itself using the immune system, it uses the magic bullets. The magic bullets, of course, are generated by white blood cells, like the neutrophils, the lymphocytes, monocytes, like that. So the magic bullets can be even cytokines, like for example, interleukins, tumor necrosis factor, and so many other components or chemical components that are utilized by the immune system as the magic bullets. So as those magic bullets are being released, they destroy the invading microbes or the invading enemies, or which are the bacteria in this case. And as they are destroying the microbes, at the same time, they also damage the normal tissues, and that marks the beginning of inflammation. And that's why, for example, pain, the inflammation has components. It has components like pain, heat, high temperature like fever, temperature change in fever. When there's an infection, expect fever in most cases. And when there's an infection and the immune system is still strong, expect fever. Yes, fever is a component of inflammation. Then swelling is a component of inflammation. Reddening is reddening, pain, and the loss of function in most cases, depending on the organ that is affected. Also loss of function. So there are mainly actually 5 components of inflammation. They come from Latin dolor, pain, dolor, rubor, meaning red, dolor, pain, rubor. Then you have functiones, loss of function. Then calor, which is heat, temperature change, fever, from calorimetry in our physics. Calorimetry, the study of heat. Calor, we have rubor, dolor, Carol, Fonctioresa, and tumor, which is swelling from the word tumor. So we see that with gonococcus inflammatory changes, now we know the meaning of inflammation. When white blood cells have been attracted to come at the site of inflammation or at the site of infection, then the release of the magical bullets like the cytokines, even the tissues being destroyed by the or damaged, they also release cytokines, not only from the white blood cells. Then tumor necrosis factor, when all those have gathered together and they have started performing their function of protecting, killing, and destroying the enemies or the invaders, at the same time damaging the normal tissues, that is when we say that inflammatory changes have begun or they have set in. So, with the gonococcus infections, we say that inflammatory changes start to appear approximately 2 to 7 days after inoculation. Inoculation, when I get my seeds and I put in the soil, and after a few days they start germinating, it means I have inoculated them. So that is inoculation. So when a male during sexual intercourse, there's union of those organs. You know what happens? So when for example microbes or bacteria from the male penis end up into the female vaginal canal. That is, and eventually they start actually causing havoc in a female who is normal. It means that is he has inoculated the bacteria into the female vaginal tract. So that is it. So with the gonococcal infections, we see that inflammatory changes start to appear approximately 2 to 7 days after inoculation. Seeding. So what happens after? We see that endocervical mucosa. Endocervical mucosa, the mucous membranes, the mucous membranes within the inner cervix. Within the inner cervix, the mucous membranes, the mucous membranes around this region of the cervix, which is the endocervix. The endocervical mucosa is the most common site of initial involvement. Gonococcal inflammation may also begin in the Bartholin's glands and other vestibular or periurethral glands. For example, skin glands, and so many others that are part of the vaginal canal are also involved. From any of these sites, the organisms may spread upward, ascending. Remember the word ascending, to involve the fallopian tubes and tubo-ovarian region. So when we say tubo-ovarian region, this is what we mean. This is the this is the ovary. Then this is the fallopian tube. This is our fallopian tube. So when we say tubo-ovarian region, this is the region that we mean. Actually, including the Brody ligament anyway. So this is the other diagram of ours, but in this case we are showing they are showing us chlamydia. By the way, neisseria, gonorrhea, and chlamydia are in the group of intracellular bacteria. So these are bacteria, these are chlamydia bacteria that I'm trying to show you. Although the illustration is the same, we see that the non-gonococcal bacterial infections that follow induced abortion, dilation or dilatation and curettage of the uterus, and other surgical procedures of the female genital tract are thought to spread from the uterus upward through the lymphatics. These are channels, lymphatic channels or venous channels, rather than on the mucosal surfaces. Therefore, these infections tend to produce less mucosal involvement, but more reaction within the deeper layers of the organs. So, let's look at the morphology or the clinical picture of pelvic inflammatory disease. Wherever it occurs, gonococcal disease is characterized by marked acute inflammation. For example, when an infection has occurred within 14 days and less, we call it an acute infection. When beyond 2 weeks, it becomes a chronic infection. So we see that wherever it occurs, gonococcal disease is characterized by marked acute inflammation, largely confined to the superficial mucosa. Superficial, this is the surface of my skin. So I can say superficial. This is the superficial anatomy of my skin. When I penetrate and go deep, it means I have ceased to be superficial. I'm going deeper. So the opposite of superficial is deep. So superficial mucosa. We see smears of the inflammatory exudate. Exudate, what does an exudate mean? An exudate is a fluid that is produced or released by tissues that are undergoing damage or that have been infected. Of course, when there's an infection, expect damage within that tissue. So, for example, you have seen burns. If my skin is burnt, there is after some, if my skin is burnt, if I sustain superficial burns, I'm going to develop maybe blisters. Maybe if, let me say, they are scars, the burns have been caused by hot water or steam, I'm going to develop blisters. Within those blisters, there is some fluid. That fluid, I can call it an exudate. So we also have transudate. We have the exudates and transudate. An exudate is usually a thick fluid. So smears of the inflammatory exudate disclose the intracellular gram-negative diprococcus. The diprococcus are the neisseria gonorrhea bacteria that we are talking about. The neisseria bacteria, they are the ones which are diprococci. They exist in pairs, dipro. Di meaning two. Then prococci, diprococci. So you can see they are existing in pairs, 1, 2, diprococci. So when we say diprococci, we are referring to neisseria gonorrhea. So smears of the inflammatory exudate disclose the intracellular gram-negative diprococci or diprococcus. However, definitive diagnosis requires culture and sensitivity or detection of gonococcal RNA or DNA. RNA, that is ribonucleic acid or deoxyribonucleic acid. Of course, we can use other methods to diagnose. Gram staining, for example. Gram staining is gram staining microscopy. Under microscopy, we do gram staining. The use of gram staining is to be able to visualize or to view the bacteria in a clear background, or we stain them with the dyes. With specific dyes, not every dye, you need to know that. And we view them using ordinary microscopes, using right microscopes. And that is when we talk about gram staining, that is what we mean in microbiology. Yes. If spread occurs, the endometrium is usually spared for unclear reasons. We don't know why the endometrium is usually spared in pelvic inflammatory disease. Once the infection reaches the tubes, at this point, my dear sisters, my dear brothers, fellow men, and our dear women, our dear mothers, our dear sisters, our dear daughters, be careful and not carefully at this point. Once the infection reaches the tubes, an acute suppurative salpingitis follows. What do I mean? An acute, you know the meaning of an acute. Then itis, the other suffix itis, meaning that there's inflammation. Suppurative means formation of pus. Where you see suppurative means formation of pus. Then salpingitis means inflammation of the fallopian tubes. That is, inflammation of the fallopian tubes is referred to as salpingitis. So there is suppurative formation of pus, a reaction that results into the formation of pus. So where there is, which is suppurative salpingitis, means there's the inflammatory reactions within the fallopian tubes that are going to end with formation of pus. Now we are going to end up with the pus within the fallopian tubes. We are going to end up with now pus within this fallopian tube. Within this fallopian tube, we are going to end up with the pus. That is what we mean by suppurative salpingitis. This is the medical language. This is the gynecological language. Don't mind, as long as you understand point by point. By the way, each and every field has its own language. You need to appreciate that. Recently, when I was watching the Chinese space program, when they were sending a team with their first female astronaut to space, they were saying taikonauts. As a person who is always curious, I decided to find out the meaning of taikonaut. What is the difference between an astronaut and a taikonaut? Little did I know that it comes from a Mandarin. It's a Chinese word, Mandarin. You know, the language spoken in China. That language is not called Chinese. We call it Mandarin. So I found out that Taikong is a word which means space. It is a Mandarin word which means space. So taiko, then not comes from a seira. It is a Greek word which means a seira. So taikong means space. So then not taikonauts then mean space seiras. Then astronauts. Astros comes from also a Greek word which refers to the stars or the star. Astros, a star. Then not, astronaut, also from the Greek word, the seira. So the star seiras, an astronaut, astronauts. Okay, back to our medicine. So, with suppurative salpingitis follows. The tubal mucosa, you know the meaning of mucosa at this point. The tubal mucosa becomes congested and is diffusely infiltrated by neutrophils. Neutrophils are the white blood cells, the category of white blood cells, then also plasma cells and lymphocytes. All these are examples of white blood cells. Now, you see, not careful, the tubal mucosa. When we mention the tubal mucosa, we are referring to the other roof, the tiling, the inner lining, the inner floor of the tube. Here we cannot see the rumen. We cannot see the tubal rumen or the rumen of, here we are able to see the rumen. Or the inner lining of this fallopian tube. So when you mention the mucosa, that is those are the mucus, the mucosal epithelial linings of this tube. When we mention the mucosa, so back to our point. So the tubal mucosa becomes congested and is diffusely infiltrated by neutrophils, plasma cells, and lymphocytes. All these are white blood cells. And remember what I mentioned in inflammation. When I mentioned inflammation, you know what happened. White blood cells come, they start releasing their magic bullets. Damaged tissues also release their magic bullets. Then you end up with the features of inflammation where you have fever, swelling, that is of course edema, that can be characterized by release of the fluid, the other exudate that I talked about. Then you have reddening, which is rubor, like that. So we see that gonococcal, now to the bacteria, gonococcal lipopolysaccharide. Lipopolysaccharide is a component of the bacterial cell wall, and particularly of the gonococcal neisseria gonorrhoea bacteria. So gonococcal lipopolysaccharide, which is a component of the bacterial cell wall, and inflammatory mediators mediators such as tumor necrosis factor. In this case, I found out is tumor necrosis factor alpha. Together, they cause what we call epithelial injury. Epithelial injury. When I said epithelial linings of the tubes, look, when I say that epithelial linings, I'm referring to the other mucosa. When I say epithelial linings, I'm referring to the inner tiling, the tiles of my sitting room, the roof, the ceiling of my sitting room. Those are the epithelial linings that I'm talking about. When I said this is the mucosa, these mucous membranes, these are the epithelial linings. Now back to our point, my dear colleagues, my dear brothers and sisters. So we see that gonococcal lipopolysaccharides and inflammatory mediators such as tumor necrosis factor alpha cause epithelial injury, injury to the tiles, injury to the ceiling, and this eventually will end up there is a sloughing off of the plica or the plici. The pricky, the sloughing off means afterwards there is a peeling off. You know, when a wound is healing, if I have a wound here and it is healing, you know what happens? You see some dead skin peeling off. So this is what we are talking about. So the sloughing off of the plicky. Plicky is a combination of dead cells, dead white blood cells with the massive epithelial linings. So we continue. The tubal rumen, meaning the inner lining of the pipe, inner lining of the tube is what we mean by the rumen. The tubal rumen fills with purulent, meaning purulent refers to pus. So from suppurative, suppuration means formation of pus. Purulent, exudate. Purulent means that it is an exudate, a fluid with pus. So the tubal rumen, the other inner pipe, inner lining of the fallopian tube, is going to end up filling with a purulent exudate or fluid with a lot of pus that may leak out of the fimbriated end. The other end that has finger-like projections is what we are talking about. Now here where you see the finger-like projections, we are going to have a lot of pus fluid filled the exudate with the pus filling with this tube, and it is going eventually to start leaking out. Octonia, gutura, overfilling and going through these ends of the fimbriated end, the finger-like projections. Eventually, they are going to be pouring into this cavity, the external pelvic cavity, of course, within the broad ligaments, and so many other structures are going to be affected as we continue to analyze and study point by point. So we are going to see, this is the point. The tubal rumen fills with the purulent exudate that may leak out of the fimbriated end. The infection may further spill over to the ovary to create salpingo. Salpingo, remember, salpingo refers to the fallopian tube. Then ophoritis, meaning the ovaries. Salpingo, ophoritis, meaning that the tubes and the fallopian tubes and the ovaries are involved together. So you can see how pelvic inflammatory disease is causing damage step by step. So in the end, we see corrections of pus within the ovary and the tube and the fallopian tube or the tubes, resulting into what we call the tubo-ovarian abscesses. These are the ones we call ibibyimba, ebizimba. When you say a tubo-ovarian mass, a tubo-ovarian abscess, it means it is a chizimba, a bizimba, a bibyimba, full of pus and other fluids. Or we end up with tuborumen, or we end up with the still correction of pus and the other suppurative, because of the suppurative inflammation, resulting into a purulent exudate. We are going to end up with the other pus within the fallopian tube, and that is what we are calling the pyosalpinx, tuborumen, pass within the tuborumen, pass within the fallopian tube, that condition is referred to as pyosalpinx, pyo referring to pass, salpinx referring to the tube. So pyosalpinx may occur. In the course of time, the infecting organisms may disappear, leaving the sequelae of chronic follicular salpingitis and hydrosalpinx. Hydro refers to water, salpinx refers to the fallopian tube, meaning we are going to end up with chronic follicular within the follicles, follicle-like chronic follicular salpingitis and hydrosalpinx, meaning water within the tubes, within the fallopian tubes. Of course, when there is pus, there is water within the fallopian tubes. Do you expect such a woman to conceive? Do you expect such a woman to produce any child? Do you expect an egg to be released and is fertilized? Do you expect male spermatozoa to fertilize, to pass through that fluid and eventually end up fertilizing, reaching the egg and fertilize it to form a zygote and subsequent a child? No. So you can see now where we're heading. Infertility in females. This is where we're heading. So what does hydrosalpinx mean? It refers to this, what are the features? There's dilatation, widening of the other tubes, dilated fluid-filled fallopian tube, meaning that the tube is going to be dilated like a tube that has been overinflated and filled with fluid or water. So we're going to end up with tubes that are full of water or the other fluid, and of course dilated. Now they're already blocked. The male sperms cannot pass anywhere. The egg cannot pass anywhere. So remember, by the time all this damage is occurring, the other hair-like structures called the neisseria within the fallopian tubes that keep on pushing the egg towards the uterine cavity, they are being damaged, they have been lost. The desquamation has occurred, loss of epithelial linings has occurred, and therefore the other cells, the other cuboidal cells that form the epithelial linings of the fallopian tubes are going to not be, even if they remain, they are not going to be having the other cilia that keep on beating rhythmically like the legs of a millipede, and in the process they end up pushing the egg towards the uterine cavity for fertilization, or if fertilization has occurred within the uterine, within the tube, the zygote that has been formed is going to be pushed story by story towards the uterine cavity for implantation and pregnancy subsequently. So that because the cilia have been lost by the infection, due to chronic inflammation, it is not the other zygote that has been formed still might end up implanting within the tube, and that is how we end up with ectopic pregnancy, or still the egg is not pushed or propelled by those cilia because they are not there. So now we proceed. Let's proceed. The tubal pricky. The tubal pricky refers to denuded. It's like, for example, when I get this phone and I keep on breaking it into pieces. This portion I break it off. I break another portion off. It means I'm denudating. You remember in geography, denudation of forces, soil erosion, then soil erosion. Then you know what happens in soil erosion, or when rocks are being roasted slowly by slowly. It keeps on breaking off in to form sand particles. We call those, that is denudating. Likewise, we see the tubal pricky refers to denudation of epithelium. When there's denudation of epithelium and adherence to one another, those parts that have been denuded or wearing off, the moment they keep on adhering, and that meaning attaching onto one another, and slowly fuse in a reparative in a reparative scarring process that forms gland-like spaces and blind patches is what is referred to as leads us rather to chronic follicular salpingitis. So when there's a sharing of the denudation of the epithelial linings, then adhering together, then those fluid containing pus come together, they form what we call a gland-like spaces or gland-like spaces and blind patches, which are correctly referred to as chronic follicular salpingitis. Yes, the lumen of such tubes may be impenetrable, meaning that the inner lining of that space in the pipe, in our tube, in our femoral tube, the fallopian tube, is what we are calling the lumen. The lumen of the fallopian tube is going to end up becoming impenetrable because of chronic follicular salpingitis, because of these denuded structures that have resulted into formation of scars. Remember, there's adherence, formation of adhesions. There's a formation of the adhesions already in the because of all these structures that have been damaged. There's eventually end up with scars, formation of scars that end up blocking the tube. And the lumen of this, and that is why we are saying here that the lumen of such tubes may be impenetrable for the oocyte. The oocyte refers to a mature egg, a mature female egg, a mature ovum is what we are calling the oocyte. The lumen of such tubes may be impenetrable for the oocyte, resulting in infertility or ectopic pregnancy. Imagine, now look at what happens. When adhesions have been, remember the egg is released, this is the ovary. So when the follicle is mature, the egg, it is going to rupture and it releases the mature egg or the ovum, the female egg. Now the fimbrial will pick it and it comes like this. So it is moving slowly due to the rhythmic beating of the cilia. You remember the cilia? The other structures which look like the legs of a millipede or a centipede, they keep on beating towards the uterine cavity. So as they are beating towards they are beating towards the uterine cavity, they keep on pushing that egg. So in the process, this female might meet a male and the sperms are deposited and eventually they swim. When they meet around the isthmus or within the ampulla, fertilization occurs. And when fertilization occurs, a zygote is going to be formed. And a zygote is formed, and as a zygote is formed, it is going to be pushed by the other cilia, and eventually it will fall within the uterine cavity and implantation will begin, meaning pregnancy will begin officially. But failure, if that process fails to happen and because the other structures have been damaged, the other cilia have been damaged by the gonococcal infection or chlamydia infection or the polymicrobial infection, we are going to end up with damaged cilia. The egg, even if it succeeds, it is going to end up around here or around here. And it is going to be fertilized from there. And the zygote is going to remain growing from with the tube. And that is how we end up with an ectopic pregnancy. And once an ectopic pregnancy occurs, it means this tube is going to rupture and the tube is going to be damaged. Well, there's good news. Currently, we have advanced gynecologists who are able to repair the damaged tubes. But again, it is time consuming. It consumes a lot of money in millions. And again, the success rate. You cannot say that tube is as original as the way it was before the infection or before the surgery. Meaning still the success rate, meaning the yes, at the end of the repair of that tube, you might get the results, but again, we can't say that we cannot compare those results to be the best as the one with a normal tube without having been infected, without any infection, without any previous surgery. So my dear colleagues, my dear brothers and sisters who are following me, who are watching, this is after the damage has occurred After all those inflammatory reactions have occurred, that is how we end up with infertility, female infertility, or ectopic pregnancy. So hydrosalpinx means water within the tube. Hydrosalpinx develops as a consequence of the fusion of the fimbria and the subsequent accumulation of the tubal secretions and tubal distension. Hydrosalpinx is another cause of post-pelvic inflammatory disease, infertility. Since lack of flexible tubal fimbria prevents uptake of the oocyte after ovulation. So remember, it's not only the malfunctioning of the fimbria, but also loss of desquamation and loss of the cilia. The cilia, C-I-L-I-A, cilia. That is the loss of cilia, the loss of the other millipede-like structures. They are microscopic structures. You cannot see them with a naked eye. But when you look at the epithelial linings of the fallopian tubes, of the airways, the trachea, the bronchial, the bronchi, and the bronchioles, they are there, those structures. They keep on in the trachea, the importance is to keep on pushing the foreign bodies that are trapped alongside the mucus towards the mouth cavity. You either spit them out as a sputum or you swallow them. Of course, children like swallowing them. They like swallowing the sputum. So that's the importance. That's why in smokers, people who have smoked for a long period of time, they have cilia, but cilia which are malfunctioning, which function poorly. They don't keep on beating rhythmically. That's why smokers usually have a characteristic cough. Every time, whenever they want to expel maybe foreign bodies with the mucus, they have to cough out. But for us who do not smoke, we don't need to cough out, to cough to expel those mucus with the trapped foreign bodies, or foreign bodies, I mean even bacteria, viruses, and the rest. That is why, of course, smokers usually have bad cough compared to the non-smokers. So we see, and likewise, cilia is also lost in females who smoke. Cilia, the same cilia, it malfunctions within the tubes of female smokers. Females who smoke, they usually have cilia that is poor in that malfunctions. That is why tobacco smoking is among the risk factors of ectopic pregnancy. So, post-PID infertility, since lack of flexible tubal fimbria prevents uptake of the oocyte after ovulation. I have said it's not only a fimbria that causes this infertility, also loss of cilia. You can, by the way, you can go ahead and read about immotile cilia syndrome, Cartagener's syndrome, immotile cilia syndrome, and so many other genetic diseases that result into malfunctioning of cilia. You remember the molecular motors, the dyneins, and what? The dyneins, the dyneins are the molecular motors in cilia that are responsible for the rhythmic beating. Anyway, back to normal business. PID caused by staphylococci, streptococci, all these are bacteria that I'm talking about, and the other puparal invaders tends to have less exudation, meaning that the fluid that is produced, the inflammatory fluid that is produced, is less. They tend to have less exudation within the lumen of the tube and less involvement of the mucosa, but a greater inflammatory response within the deeper tissue or layers will occur in the case of staphylococci and streptococcal bacteria. You might say that you might ask a question that how do the staphylococci, you might ask a question that how do the staphylococci, streptococci also end up in the uterine cavity, in the fallopian tubes, what? I said during, for example, procedures like dilatation and curettage, when we are removing the products, the remnants of conception, the products of conception following an abortion or a miscarriage. It might happen, the environment might be unsterile, it might be dirty, it might be contaminated with the bacteria. The instruments the surgical instruments, it might so happen that one of the instruments that we are using, maybe ultrasound, maybe a curette, it might be contaminated with those bacteria, and eventually in the process of doing the procedure and evacuation, dilatation and curettage, we end up introducing the bacteria there, and the process of pelvic inflammatory disease begins. Then also common PID is due to gonorrhea, gonococcal infection, or chlamydia infection, or both, during sexual unprotected sexual intercourse. Having unprotected sexual intercourse, of course, whereby one partner might be infected with gonorrhea or chlamydia. That is common. That is the common root. That is the common root of PID, the common cause of PID. And having unprotected sexual intercourse with the one partner having gonorrhea or chlamydia. So we see that these infections often spread throughout the wall to involve the serosa and the broad ligaments, pelvic structures, and the peritoneum. Serosa is the other layer, the other sheath that covers the outside of the uterus. That is the serosa. Then the broad ligament I have already presented to you. Pelvic and other pelvic structures and the peritoneum. Peritoneum is the inner lining, is the lining, the other roof, the other floor that lines the intestines, that covers the intestines, the inner lining of the abdominal cavity of the abdomen, the inner tiling, the inner cement of the abdomen, of the abdominal cavity, is the peritoneum. If, for example, I can call this wall behind me a peritoneum because it is lining the sitting room. It is lining this room. I can call the ceiling above the peritoneum. I can call the tiles where I'm seated, actually the floor, the peritoneum. So together, the inner lining of this wall, the ceiling, the tile together, I'm calling them the peritoneum. And within this room, if there are intestines and they are being covered by the wall, by by the walls laterally, superiorly by the ceiling, and inferiorly by the tiles or cement, together we can call it the peritoneum. So this is the broad ligament that I'm talking about. This is the broad ligament that I'm talking about. This is the broad ligament. Then this wall, or the sheath that is covering the uterine muscle, the myometrium, is what we are calling the serosa. This is the broad ligament. Then beyond the broad ligament and within the layers, I mean the walls surrounding the intestines, the inner abdominal cavity is what we are calling the peritoneum. So these infections often spread throughout the wall to involve the serosa and the broad ligaments, pelvic structures, and the peritoneum. Bacteremia is a more frequent complication of streptococcal or staphylococcal pelvic inflammatory disease than of gonococcal infections. When I say bacteremia, meaning bacteria present in blood. Emia refers to blood. Bacteremia, bacteria present in blood, we say that bacteremia. We call that condition bacteremia. So, the acute complications of pelvic inflammatory disease include peritonitis, inflammation of the peritoneal wall, the peritoneal lining, or the one that surrounds the structures like the intestines, the liver, the uterus as well, like that, and other organs. So, they include the peritonitis, meaning inflammation of the peritoneum, and bacteremia, which in turn may result in endocarditis. Endo means inside. Carditis, cardiac, the heart. Endocarditis, meaning the inner lining of the heart. Have you seen what gonorrhea can cause? My dear colleagues, my dear followers, I hope you are seeing at this point what just a mere gonorrhea infection, which you have been calling simple, or which you have been taking lightly. I hope you are seeing what chlamydia, what gonorrhea, and the other infections with down there from the female reproductive tract. You are seeing how you can end. The acute complications of pelvic inflammatory disease include peritonitis, inflammation of the peritoneal lining or the peritoneal cavity. You already know it. And bacteremia, which in turn may result in endocarditis, the inner lining of the heart. That is what we call when the endocardium of the heart is inflamed, the condition is referred to as endocarditis. We are seeing from PID, from just PID, gonorrhea or a mixture of polymicrobes, polybacteria. Eventually we are ending in the heart. I hope you are seeing from the now peritonitis, the abdominal cavity is inflamed. The whole of it involving, by the way, it goes ahead to involve the intestines, pus formation within the intestines as well. Having from PID now to peritonitis, I hope you can see why we are ending. Bacteremia, presence of bacteria in the blood, too much bacteria in the blood, from bacteremia to sepsis, you know what happens, which in turn may result in endocarditis, inflammation of the inner lining of the heart. Meningitis, meninges, these are the inner coverings, the coverings of the brain. The jackets of the brain, the jackets that you wrap or that cover the coverings of the brain, those are called the meninges. So when they are inflamed by the other bacteria, we end up with what we call meningitis. And suppurative arthritis. Arthro refers to the joints. This is a joint, this is a joint. These are joints. These are joints. These are metacarpal pharyngeal joints. This is the wrist joint or the carpal joints, carpal joint or the carpus. This is the elbow joint, the ankle joint, the pterocrural joint. So arthritis is the inflammation of the joints. Now suppurative, I had already explained it. Suppurative means pus formation. Now we are going to end up with inflammation of the joints with the pus formation in the joints. That is what we are calling suppurative arthritis. The remote now, let us proceed from here. The remote sequelae of PID include infertility, failure to conceive, and tubal obstruction. I am taking time to explain the PID and its complications because these cases are very common. There are very many women, we always encounter in practice very many women with the PID, and subsequently they end up with infertility. Many girls, many younger ladies have this condition, and most of them end up with infertility. They end up with they are always ending up with the ectopic pregnancies. Gynecologists, fellow doctors, fellow medical officers who are in practice actively are aware of what is happening. And it is not only in Uganda, it is worldwide. It is worldwide. That is why, if you're a gentleman, if you're a man, and you happen to suffer from gonorrhea, you happen to suffer from chlamydia infection, please complete your treatment. If you know that you have your girlfriend, I kindly request you to always also inform her and tell her to go for treatment as well. Because for my dear brothers, dear fellow men, for us, gonorrhea mistreats us. Just today, I might meet her today, and maybe if I'm unlucky, I contract gonorrhea. Me just the following day, in 2 days, or after 3 days, if I have delayed, I'll start actually groaning as I'm passing urine, susuring. I'll start groaning in pain. I'm not, I think I have chlamydia infection or gonorrhea. Let me go and seek treatment. I will go and complete the treatment. Maybe for 2 weeks or 3 weeks, I don't know. I don't want to prescribe here. Then afterwards, do you know what will happen? Afterwards, I may, after completing my treatment, I will go back and again contact more infection, again more another dose. Again, after 1 day or 2 days, I again present with the same gonorrhea. Why is it that medications are not working? Kumbe they are working, but again, I have not ensured to make sure that my sexual partner is treated. So when you suffer from gonorrhea, always seek treatment very, very fast. And then after seeking treatment, complete the dose, the course of the dose course, the course of the treatment course, complete it. If the doctor or the clinical officer or the clinician has said that, has instructed you to complete the dose for 2 weeks, which are 14 days, a fortnight, complete the dose. Don't say that I'm now okay after 4 days of treatment, or treatment 5 days, I'm now fine, I can stop, throw away this medication. My brother, you are going to end up, my brother, my sweet dad, you are my son, you are going to end up causing antibiotic resistance. Then after treating yourself, after completing the course of treatment, as you go to seek for treatment, by the way, you should also inform your sexual partner, your girlfriend, your wife, whatever you call, whichever title you use. You must also inform her that please also start this course of treatment so that you don't stop infecting each other. Okay? So if you know that you, as a male, if you know that you have a girlfriend who is innocent, your wife is innocent and she doesn't have the infection, and you say you go somewhere and maybe you contract gonorrhea, don't go home. Don't go start sleeping, having sexual intercourse with your girlfriend, with your wife, and you start infecting her, because after infecting her, she's going to end up with eventually. Remember, gonorrhea, chlamydia infections, these infections are usually silent in females. For they just keep their silent. They don't mistreat them, by the way, like us. Gonorrhea does not mistreat females, it mistreats males. That's why for us, we develop infection. We see the signs and the symptoms of infections, of the infection, within just 1 or 2 or 3 days, or within the first 10 days, or following the sexual intercourse, and protected sexual intercourse with an infected female. In females, the infection does not, by the way, treat them. A female can be there without knowing that she even has gonorrhea, without knowing that she has the chlamydia infection. Then for you go there, you get it. When for her, she's not even complaining. You say, but yesterday, after doing it, after celebrating yesterday, today, 2 days later, I'm seeing 2 days ago we celebrated together, and I have not passed any other through any other path, through any other route. It is only you. But now I'm seeing some pus from my urethra. I'm even groaning. I'm feeling pain down there. I don't know what is that. I think you infected me. You have some infection. Go for treatment. Then if should tell, but you know what, honey? Me, I'm not. I don't have any problem. Because for them, she will not complain, because in most cases, gonococcal infections, chlamydia infections remain silent within the females. And that is how they end up with pelvic inflammatory disease with the time, because the infection does not mistreat them. That is why, if you, as a male, because we are the people who end up, who keep on spreading this infection to them, and again, we get it from there like that. So, if you have your sexual partner and you are going for chlamydia treatment as a male, or gonococcal treatment, or treatment for gonorrhea, always we treat 2 people, including the sexual partner. That is how we are able to prevent PID. Otherwise, if you don't also complete the dose, the course of treatment, problems. And females, I hope for females who are following me, you know what I'm talking about. This condition is very, very common in 10, let me tell you, in 10 females in the reproductive age group, in a sexually active group. In every 10 females, always know that 4 out of 10 have at least have that infection or have PID. 4 out of, 3 out of 10. That is by the big percentage. So let us progress. Let's proceed. Bacteremia is a more frequent complication of streptococcal or staphylococcal PID than of gonococcal infections. The acute complications of PID include peritonitis, well, we already know it, peritonitis and bacteremia, which in turn may result in endocarditis, meningitis, and suppurative arthritis. The remote sequelae of PID, the remote means the wrong term. The remote sequelae of PID include infertility and tubal obstruction. Infertility, you already know it. Then tubal obstruction, blockage of the tube of the fallopian tube. Increase the risk of ectopic pregnancy, chronic pelvic pain, as well as intestinal obstruction. The intestines might twist due to adhesions between the bowel and pelvic organs. Because of the other suppurative exudates resulting from chronic inflammation, adhesions form. The surfaces of the outer surfaces of the intestines start sticking onto those pelvic organs, and eventually when the intestines become sticky because of the other adhesions resulting from the fibrous scars, eventually obstruction of the intestine will occur, and the other contents passing through will not get where to pass, because maybe the intestine which should be straight like this has been kinked or folded because of the other adhesive surface outside onto the pelvic organ. Now the contents which have been going through like this or going through, eventually because there is a kinking due to adhesion and fibrosis, the other lumen of the intestine is broke, and eventually the patient ends up with intestinal obstruction. And eventually, where is the end? Theater. Operating theater, hospital operating theater. I don't mean the other drama theater. So, we see that in the early stages, gonococcal infections are readily controlled with antibiotics, although penicillin-resistant strains have regrettably emerged. When the infection becomes walled off in tubo-ovarian abscesses, it is difficult to achieve sufficient levels of antibiotics within such infectious foci, and it sometimes becomes necessary to remove the organs surgically. So, post-abortion and postpartum PIDs are also amenable to treatment with antibiotics, but are far more difficult to control than the gonococcal infections because of the broad spectrum pathogens that may be involved. So, what is the treatment of PID? My dear brothers and sisters, I would be comfortable to share these medications, but because we are in the era of advanced antibiotic resistance, that is why I'm not comfortable to share antibiotics which we use. Because when I start sharing antibacterial agents that we use, I'm going to be encouraging self-prescriptions, and self-prescriptions are very bad, very dangerous, and especially when it comes to antibiotics. We are battling an era of antibiotic resistance worldwide. It is not only in our country, but worldwide. So that's why on this point of treatment, I'm advising you to always go to the health care facilities, consult and be managed by qualified health workers, and above all, complete the doses of the prescribed medications, because it's dangerous not to complete the doses and the course of treatments. That's why many females are always ending up with ectopic pregnancies, infertility, because they don't complete the courses of treatment. If you find a doctor has prescribed the medications for 2 weeks, she only swallows medications, she takes those medications for only 5 days. And she says, I'm okay now, the infection has resolved. I can now conceive, I can now do my things, and I conceive. Then after conceiving, later on, the infection remains silent. It goes ahead to cause PID, damages the tubes, the cilia, the fimbria, then infertility occurs. If infertility does not, or if she survives infertility, she ends up with an ectopic pregnancy. That tube is kaput, damaged. Then another time she tries, after some months, she tries again to conceive. She again gets an ectopic pregnancy. That kaput, that tube is also damaged. She ends up without a child. She ends up without a child. And remember, I told you that the good news currently is that some gynecologists in our country and beyond, they are able, they can repair those tubes. But again, how much are you going to spend? Millions of money. And even after spending the millions of money, it is not a guarantee. Even the surgeon himself or herself, the gynecologist who is also a surgeon, is going to tell you that my daughter, my sister, my sister, my friend, I'm not giving you 100% guarantee that you might not get an ectopic pregnancy again. No, it is he will tell you that yes, for us as doctors, as gynecologists who are also surgeons, we have done our best. The chances of conceiving and avoiding an ectopic pregnancy are at around 60%. 65, he or she will tell you the truth. If he is a good professional, he will tell you the truth. I know, yes, you have spent this money in the treatment, but again, I will not tell you that is 100%, is not 90%, at least it's around 65%. You need to be assured. So why should you wait to reach that point? My dear sister, my dear wife, my dear mom, my dear friend, why, as a female out there, why should you wait to reach that point of spending millions of money when you of being childless, of lacking a child? What about those mothers, those females out there who do not have these millions to spend? What about them? And they are the majority worldwide. So my dear colleagues, my dear brothers and sisters who are following and watching me, when you need to take this topic seriously. And remember, I have said that it's not only females who should be involved because they are affected the most. No, both of us. We are the people who give to them those infections, and they also give to us, like that, vice versa. We don't get them from animals. No. We don't get them from animals. It is between ourselves, mainly through sexual intercourse, unprotected sexual intercourse with the one partner having the infection, and it happens. It happens. So please be very, very careful. Don't call me a selfish doctor, a bad doctor who is refusing to share the medications. Yes, I also need to emphasize this point before I conclude. I also have to say that I'm sorry, it's unethical and harmful when I share the medications on this platform. Thank you for watching and listening. However, I know a good number of you like studying medicine just in 10 minutes by using Googling. You guys say, I don't need to go to the hospital. I don't need to go to any clinic. I don't need to consult any health care worker. I can Google treatment of gonorrhea, ciprofloxacin. You abuse it, metro. Chlamydia, you can use tetracyclines and they work. You are going to cause a lot of more harm to yourself than good. Yes, you will treat those symptoms, but again, a lot of other things might occur. You might be reactive to a certain medication when you don't know. You might be having resistance. Maybe you might have been treated for tuberculosis, and along the way, in the course of treatment, they might have used maybe fluoroquinolones where ciprofloxacin follows, and eventually, maybe you find that it is even resistant, that it no longer works for you. So that's why I will keep on encouraging and advising you to go to any health facility so that you are treated by qualified health workers when you are battling such an infection. That is it. So then also it is also very dangerous, by the way, to keep on abusing Cipro and so many other medications, especially ciprofloxacin. You are going to keep on using it to treat your PID or to treat your gonorrhea, what. Fine. You are going to achieve good results. But in the near future, you might end up suffer from tuberculosis. And tuberculosis, which is maybe multi-drug resistant tuberculosis strain, and eventually they need to use, they reach a point where they said, if these regimens are not working for him or her, why don't we now resort to fluoroquinolones? Why don't we include a fluoroquinolone in the new regimens so that we treat this her TB? And eventually, because you have overabused the fluoroquinolones, they will not work for you, and TB will kill you. TB will kill you. And in that case, will you blame the physicians who will be treating your tuberculosis? No. Will you blame the gynecologist whom you did not consult when you are suffering from your gonorrhea or PID? No. Will you blame your doctor or the medical officer? No. So that is it. Thank you for watching and listening. We'll link up in the next subchapter when I'll be sharing another interesting topic. Thank you very much for watching. Bye-bye.